I'm not sure how much I'll use these slides actually, but we'll have them up behind anyway. I usually, when I'm speaking, I love to wander around the place, but I'm told I have to stay in the same place or the cameraman will get dizzy, so I have to stay here. But that will be a little bit difficult for me, but I'll try. The lot of the palliative care, anybody working in palliative care, is when you get invited to speak at something, you're always the last speaker of the day. Everyone says, oh, we'll do palliative care now. So you're always there. The most memorable one, I was speaking at something in Dublin Castle years ago, and as I stood up to speak, not only had the room pretty much half emptied, but there was a guy at the back who was stacking the chairs as I started to speak. So, well, it kept me moving, kept me going. There's a couple of things go with palliative care. The one is, when you tell somebody you work in the hospice or work in palliative care, that always gets the same reaction, and the reaction is, it's a mixture of pity and God, you must be very special. And for a while you believe you are very special, and then you grow out of that a little bit as well. And the next question that comes is, well, how did you end up working in palliative care? Because people, I think, imagine that is just a terrible place to work and a terrible, gloomy, dark place to pass your day. And it's very far from that. And I suppose for myself, there were a myriad of small things and one or two big things that drove me towards palliative care. And the biggest one probably would have been my own dad being ill, being diagnosed with cancer, and the experience of his 18 months between diagnosis and death, and the things that happened along that road pointed out to me what was important and what wasn't important. And again, it was actually the little things that were important. It was the simple things that were done very well that made the big difference. And I was a doctor when he was diagnosed, and as it happened, I was working with a diabetes team. So when my dad got sick, I do as you do, and I went and I spoke to the consultant I was working with. So my dad, who didn't have diabetes and never had diabetes, ended up being looked after by a diabetic specialist. Made no sense, but that's what happened. But what was amazing about the consultant was how often he came to see my dad just to say hello. Now, a lot of the time he really didn't have anything to say to my dad except hello, but how much that meant really made an impact on me, and would make an impact, I hope, on how I practiced myself. Then later down the road, when the hospice services were involved and Dad was at home and he was very ill, and we were very keen for him to be at home, but we were really floundering. And I was probably floundering more than anyone else, because as the only medic in the house, I sort of felt I should do stuff, but I didn't know what stuff to do. And I remember some of the nurses who came to the house, particularly some of the night nurses who came. And again, it was just the little things they did. They managed to calm everybody down. It wasn't anything very clever they did, anything very complicated. It generally wasn't anything to do with medications, but it was just little things they said made the difference. And we could stay at home, and Dad could stay at home. And then it reached a stage where things got difficult and we needed to go into the hospice, and there really wasn't a choice to that. And so a little bit reluctantly, in we went to Harold's Cross. And in we went, and we arrived, and we were met by somebody at the door, which was actually a very good thing. You know yourselves, you go to a hospital, it's big, you're lost, trying to find your way, whereas actually we arrived, it was a fairly small building, somebody met us at the door, they took us down straight away to the bedroom, got into the bed, a big pot of tea arrived, and Dad, who was a little bit confused, turned around to my mum to say, "Are you sure we have cover for here?" He was impressed immediately. So again, the pot of tea made all the difference. So palliative care isn't just about pots of tea, but I think it is about doing simple things very, very well. So what I want to do today is to tell you a little bit about what I do, and from that what palliative care is and what it isn't. I think most people have a pretty clear idea what hospice is. I work in Harold's Cross, one of the hospices in towards about 5 miles from here, I suppose, long known as the Hospice for the Dying. And how that hospice came about was it was founded by the nuns who worked in St. Vincent's, and St. Vincent's Hospital was originally on the Green. And some of the nuns there noted how many people were dying in the hospital, and they felt this was a bad place to die. And in some ways it possibly still is in an acute hospital, but they noticed this 150 years ago, and they said, look, dying in this hospital in the middle of the city, it's a terrible thing, we should have somewhere for the dying patients to go. So that was how hospice came about. And the hospice then, they said, we'll go down the country, we'll get somewhere far away from the city, lots of animals, greenery around, a peaceful place for patients to go. So they went to Harold's Cross. Obviously the city has since expanded a little bit, but that was the idea. So this big greenfield site in Harold's Cross became the hospice. And there's a lot of argument about whether we're the first or second or third hospice in the world, but we're certainly among the 3 oldest hospices in the world. We argue as to who's first. So that was how hospice began in Ireland and indeed worldwide. So it was somewhere for the imminently dying to go, and the care would have involved a lot of candles, a lot of Bibles, and perhaps not much in terms of medicine or nursing or science. And it was that way for many years. And you were appropriate for the hospice if you were in your last days or weeks of life. Now that changed in the late 1960s with a lady called Cicely Saunders in London who said, this isn't good enough. We need to do more for people who are dying. We need to look after them really well. It's not enough just to give them a nice environment. So Cicely Saunders medicalised and brought active care to palliative care and totally changed what palliative care was. And she was a visionary lady who started off as a social worker, then became a nurse, then became a doctor, political activist along the way, married one of her patients, which is very bold, you're not supposed to do that. And there was considerable ambiguity in her biography as to when they got together, herself and the patient. So she was a great lady and really drove things forward. And she died only about 6 or 7 years ago. I got to meet her. She came to speak in Dublin at the same conference actually where they were stacking the chairs. But she changed palliative medicine. Now her focus was on cancer, and palliative medicine or hospice care became about care for cancer. And now in more recent years it's shifted again, and we've gone from being focused on the prognosis to the diagnosis to palliative care is for people who will benefit from palliative care, which sounds like a circular argument, but maybe you'll see as I talk more about it. So palliative care services work in really 3 different settings. We work in the community, and you've probably heard of your local home care team. Sometimes in the UK they're the Macmillan nurse, sometimes they're called the Daffodil nurse here. But these are nurses who see people at home with progressive, incurable illnesses. Now, how sick are people before they're referred to palliative care? That's maybe the one thing I want you to, if there's one thing you remember from today, or from me anyway, I want you to think about this. When I see a patient for the first time, half of the patients I see will die within 6 weeks of that. So I'm seeing very, very ill patients. I'm seeing patients at the end of life, and that is very much at the heart of what palliative care is. But half of the patients I see are going to live longer than that, and some will live months and some will live years. And when I was thinking about this yesterday, I was able to count. I can think of 4 patients who I've known for more than 10 years now, who've been attending my service for more than 10 years. So we sometimes see patients for quite long periods of time. And the interval between when we become involved and when a patient dies is continually broadening. And this is a good thing. And there's a couple of reasons for this. I suppose the things that are at the core of palliative care, which would be symptom control, communication, planning, those things are important at all stages. It doesn't matter what your illness is, your symptoms should be well controlled, you want good communication, and you want to make plans. That shouldn't be reserved to the last week or 2 or 3 of life. So palliative care is pushing backwards. And what's come out, it was in 2009 and then a couple of studies since, are studies which showed what we felt instinctively but was never proven, which is that for cancer, if you involve palliative care earlier, patients tend to have lower symptom scores, they have better quality of life, there's less frequency of depression, and we sort of knew all of that and there was evidence of that. But what's come out more recently is that patients with earlier palliative care involvement live longer. And that's a real surprise maybe. And it's still very much trying to get that word out there and getting that word out to patients, to families, but even more so getting it out to doctors for them to realise that, because the nervousness about palliative care isn't just among patients or families, it's very much among healthcare professionals. There's an anxiety about palliative care, a concern that involving palliative care means that you're raising the white flag, you're throwing in the towel, you're giving up, you're not doing anymore. And palliative care is very far from that. It's very far from that. So palliative care is becoming involved earlier in the day, and it's very rare for me to see a patient where there isn't something I can do to help, be that in their last week, their last month, their last year. And I much prefer to see the earlier patients and have time. And what happens now is that I may see someone, there may be things, for example, they may have pain from something or other, and we work on that, we address that, we make progress with the pain, and then I say goodbye. And I might see them in a month's time, I might see them in a year, I might never see them again. But there's a sort of an in and out contact, and palliative care is becoming more of that. It isn't that you're signed up, you're on the very last days, and this is it, it's all going to happen very quickly. Palliative care is becoming involved in patients' care much earlier, so that really is something to think about, hopefully. So this is a very short way of describing palliative care, I think. Most of medicine and most of hospital care, if you think about it, is directed at when you die and pushing that away. And that's entirely appropriate, and that's as it should be, and that's a very good thing. Palliative care is less focused on that. Generally, people I'm seeing have an illness that can't be cured. It's not that it's incurable because they're seeing me, though sometimes people mix those things up. They're seeing me because the illness is incurable. And usually I'm not the person who can change that gap. Now, there will be changes if a patient, as I said, if a patient sees us earlier, their symptoms may be better controlled, they may be better able for their chemotherapy, they may be better able for their surgery, they may live longer. But our focus isn't so much on quantity of life, it's quality of life. So it's not when you die, but how you die. And dying isn't something that happens in an instant or a moment. People can die over long periods. We all, I suppose, in some senses are dying, but we don't think like that. But you can reach a point with your illness where you know you are dying, and it may be out there and you may not want to think about it, but you know it's out there. And it's the gap between here and there, and making that gap, which is all the more important because it's finite, making that gap as good as possible and having the care that's right for that. That's what we do. That's what palliative care is about. And there's a lot of diversity in terms of what people want. People live very differently, people are ill in very different ways, and people die in very different ways. So there isn't a one size fits all. And what people want from their medical care, really there's no predicting it, and I'm forever being surprised by different people who want different things. And I see people of all ages. Yesterday was, I think, a unique day for me. I saw two people with a combined age of 100, but one was 97 and the other was a 3-year-old I saw in the morning. And again, what we're trying to do for a 3-year-old and what we're trying to do for a 97-year-old, obviously very different things. But that diversity and that individualization of care, again, I would hope is a hallmark of what palliative care and hospice care is about. And I think the bottom line there, by that I mean, is what people want changes with time. So you may be at a stage in your illness where your priority is getting back to work. And that's really, you want everything, get all the other stuff out of the way. I want to get back to work, I want to get back to my normal life. Or you may be at a different stage in your illness where your priority is, well, look, I want to be able to, spend a morning with the kids without feeling too tired. Or it might be a different stage, I want to be able to get out of bed and go to the loo on my own. So the goals change, and what people want and what they need change. And again, palliative care is about trying to move that and match what we provide with what the individual wants and what they need. So I suppose palliative care isn't standardised in the same way that perhaps some other cares are. When should palliative care be involved? As I said, it used to be you waited till time was very short and then you went for the palliative care doctor or team. Hopefully that is changing. It is changing. We're certainly keen to be involved much earlier, and there's benefits when we are. And as I said, there's sort of 3 things that we do. Control of symptoms. That's probably the most important thing that we do, because communication, quality of life, planning ahead, all of those things are obscured and crowded and difficult if you're physically in pain, if you're vomiting, if you can't eat, if you're short of breath, if you have a headache, if you're too tired. So those physical symptoms, they are front and centre. They have to be addressed. They have to be well looked after. So that's probably the primary thing that we do. And sometimes people get a little worried that the treatments we're giving, that they're not treating the disease, we're only treating the symptom. Well, the difference, and I think that's often the case, but I think it also makes sense. Think about this. If you break your leg and you turn up in the emergency department, your leg is going to hurt like anything. They're going to come along and hopefully, you won't wait too long, somebody will come along and they'll probably give you an injection of a painkiller. Now that painkiller will do nothing whatsoever to make your leg better, but it will make you feel a whole lot better. And a lot of the time in palliative care, I may see people with conditions where we can't fix the condition, or we can't fix the motor neuron disease or the cancer or whatever it is, we can't fix that problem. But downstream, it's causing a whole lot of other problems and we can't fix those. So, okay, we haven't fixed this, but these 3 things down here, we have fixed them, and that makes all the difference. So yes, we're not treating the disease, we're treating the symptom. But again, think of that with a broken leg. You very much welcome the injection for your painkiller, even though it does nothing for your leg. And a lot of the time, palliative care is focused on the symptom. We try to see things in their entirety, or we try to see people in their entirety. And we talk about total pain. It's a phrase we use in palliative care. And the example is the person who comes to me and they have a pain in their leg. Let's say they have a lung cancer and it's affecting a bone in their leg and they have pain there. They need painkillers for that. They need that to be sensibly managed. But there's probably a whole lot else going on for them. And having cancer, and I heard it mentioned by the previous speaker, brings so many losses. There are lots of things that change in your life. One minute you're well, the next you have cancer, and actually the world never is quite the same again. The world may piece together again, it will go on, there will be a different way of managing, but it isn't quite the same. And all those changes, all those losses can affect how a person is. So in palliative care, or say if you're in the hospice at our ward round, typically we'll have 6 or 8 specialties sitting around the table. There'll be doctors, there'll be nurses, there'll be physios, OT, social worker, complementary therapist, chaplain, and possibly 1 or 2 more. And that sort of multidisciplinary care is, again, a hallmark of palliative care, because we don't have anyone on the team who's good enough to do everything. There's nobody on the team who can look after everybody, who knows what everybody needs. Those people don't exist. We need lots of people with different skills who can come in different ways and come in and step back as they need, depending on what the person wants. And a lot of what we do is about communication and talking to people. And how much information people want or don't want is a really delicate thing, and it changes with time. And those of you who've been ill, who've been through systems, will have gone through days probably where you were frustrated because nobody would give you a straight answer. Nobody would tell you what was going on. What exactly was on that scanner? What did you find at the operation? Or what does that blood test mean? And you're looking for information and you can't get it. But there may have been other days where actually, I don't want to hear anymore. I've got enough at the minute. Just, okay, leave it at that for the minute. I don't want to know anymore. And what we're trying to do is gauge what people want to know and give them that amount of information. So we're not saying to people you shouldn't know or you should know. We're trying to work out what's right for that person at that time. What we do know is that how much information people want is very culturally specific. But for an Irish population, about 80 to 90% of patients want to know everything. They mightn't want to know it all today. They mightn't want to know it all at one sitting. But actually 80 to 90% of Irish patients want to know how good or bad things are, what's the plan from here, and what my chances are. Now, they mightn't be pleased with the news, they might find it very difficult to hear the news, but they want to know. But certainly 80 or 90% of patients aren't told everything. And again, some of you may have experienced that. And there is very strongly a sort of a paternalistic view within, particularly medical care, I would say, where we tend to protect the patient by not saying too much. And the doctors are at fault for this, bold doctors. But it's not just the doctors, it's the families as well. And there's a big discordance. While we know that the vast majority of patients want to know, quite often the family doesn't want the patient to know. And again, we can all think of the very obvious, kind, good, well-meaning reasons for that. But that can be tricky. And if you think about that, whose decision is it? Is it Mary's decision? Mary's 30. Is it Mary's decision whether she's told or not? It's hard to argue against it. It's got to be Mary's decision, doesn't it? But what if Mary's 90? And there's an ageism comes into this. And if Mary's 90, we tend to say, well, look, we'll talk to her children first. And they might say to us, well, really, Mary, she wouldn't want to know. What do you do there? So that's a difficult situation that comes up, I would say, almost every week in my practice. I would come up with that situation. And what do you do? And obviously, like all these things, it's about negotiation, it's about taking a little bit of time, and often the right answer is in a grey space rather than black and white. But ultimately, I think the decision has to lie with the patient. It's up to them whether they want to know. And as I said to you, even patients who are very upset when they hear what they hear, almost always, not always, but almost always, they'll be glad that they know. Because there are things they want to do, there's things they want to plan, there's decisions they want to make. And it's hard to make a decision if you don't have the information. So in palliative care, we're very much keen to give people the information they want. In general, we find patients want to know lots. And if people want to know, we will tell them. We'll try and tell them gently, but we will try and tell them. So gentle honesty is what we try and practice. As I said, there is this slowness to discuss sort of serious illness, how bad it is. There's lots of reasons for that. Prognostication is something that we are extremely bad about. And you know the question that people ask, how long have I got? Is it 3 years, 5 years, 6 months, 2 weeks? What are we looking at here? We're actually not good at that. As doctors, we're not precise at that. So that's part of the reason we don't want to talk about it. In general, I would say your doctor or your surgeon can probably tell you whether it's days, weeks, months, or years. They're not so good at putting numbers in front of those units of time. And if they do put a number in front of it, if you think that somebody said to you 3 years, 3 years is then going to be a statistical average. So the average man in Ireland is 5'10", but you know what? Not everybody's 5'10". So if you hear 3 years, that means the average is 3 years. Doesn't mean you're going to be 3 years. Doesn't mean you're going to be 6 months or 10 years. It's just an average. So prognostication is difficult. Hope I want to talk a little bit more about in the moment. Fear of being blamed, that can happen. Shoot the messenger is a tradition that lives on. Time constraints. I think sometimes in the hospital, and again you'll have found this, and again a previous speaker mentioned it, I'll say Scandinavian because I won't get in trouble then. It can take time to have these conversations, and sometimes it's very difficult to slow people down enough. You mightn't be ready for a quick conversation, but you do want to talk about this. Or you're sitting in the bed and you're sitting there in your pajamas or your night dress or whatever, and suddenly at the bottom of the bed, it's 7:45, you haven't got out of bed yet, and there's 7 people at the bottom of the bed, and you've been asked, do you have any questions? Well, what time is it is probably the only question you can think of. So it can be very hard to think, what's the thing to ask? So write these questions down, have them ready. Okay. And I think a little bit as well that sometimes it's very hard to hear the news even if you're told that. So very often people need to hear what's going on more than once. And don't be shy to ask. I mean, I welcome the patient who comes into my clinic and sits down and produces the notepad and says, well, I have questions for you. Great, brilliant. How many are there? 22. Great. We'll answer them briefly. Okay. But that actually makes my job much easier. And for the team, the doctors, the nurses you're visiting, write down your questions. It actually makes things much simpler for you, much simpler for them. They don't have to dance around wondering what you want to know, what you don't want to know. Answer the questions. And there'll be some they know the answer, there'll be some they don't, there'll be some they know a bit of the answer but not all of it. But fire those questions away. The big thing that comes up, and the reason why people are reticent sometimes to discuss exactly what's going on is a fear of taking away hope. And similarly, people sometimes don't want to involve the hospice team or the palliative care team because you're taking away hope. And again, I get that. And again, we can all understand that, and there's real logic to that. But I don't agree with it. Because hope is a fluid thing. Hope is not one thing. We don't all have one hope that doesn't change with time. As your situation changes, your hopes and your expectations change. And hope can be preserved even as it changes. And there's the slide I wanted. It's not there, wrong slide. But if you think about this, and this is a somewhat gloomy slide, I meant to put in a different one, hopefully we'll come across it later, but what people hope for changes. And sometimes you have to help people change a hope from one to another. There's another definition here, which is one that took me a while to get my head around, but we talk about quality of life. It's actually very difficult to define quality of life. But one definition of it is this, which is an interesting one, and it's the gap between where you are and where you expect to be, or where you're hoping to be. And if you're saying, God, I want to have kids and a good job and a nice house and be healthy, and I have all of those things, your quality of life is probably good. If you're my 7-year-old, and you want to be able to fly, and you can't fly, every day is a disappointment. So the gap between where you are and what you're expecting can affect your quality of life. And I suppose sometimes what I would see is patients who are hoping for something that is long gone. It's long, long gone. but they wake up every day hoping for it, and actually that hope can hurt, and that hope can be counterproductive. And sometimes what I'm trying to do is not to take away that hope, but to move it or to change it. If they have a target that is so far out there that they can never get close to it, and that's all they're focused on, it's very hard to enjoy the moment you're in and the life you're in. So sometimes what we're doing in talking about what is going on is reframing that for people. And the example where is this slide? Let's see if it's here. Nope, it's not. Okay, that wasn't helpful. The example given is, or the same author said, look, if you go to Vegas, you might hope to win $1 million, but you don't plan on that basis. And he's right. You all go to Vegas, everyone says, right, I'm going to try this, I'll put in my whatever amount of money it is and see if I win $1 million. But you don't plan your life on that basis. And similarly, it's okay for people to hope that, I'll be the 1 in 100 or the 1 in 1,000 or the 1 in 10,000, and I prove them all wrong and I do brilliantly. Great, okay. But you can't base all your plans on that. And I suppose that transition is a little bit what we're about. Now, where are those slides I skipped by so quickly? Okay. In terms of end-of-life care planning, it's a very gloomy subject, isn't it? But again, if you think about that, most of us want to have a vote in what's going on in our lives, and particularly in your healthcare. When you're ill, a lot of decisions are taken away from you, a lot of autonomy can be taken away, so you do want to make the decisions you can. And again, I think prioritising that and focusing on that is very helpful for people. So, if somebody's very ill, where do they want to be? And if I'm seeing people who are very, very ill, where do they want to be? Do they want to be in hospital? Do they want to be at home? Do they want to be in the hospice? What do they want? What's practical? What support do they need? What support do their family need? What are their priorities now? Is it for them? And for some people, absolutely what they want is every last intervention that might give them an extra day, an extra week. And that's absolutely right for some people. But for some people, that isn't right. For some people, it's more important about the quality than the quantity. And what's their priority? What do they want? And actually asking people and find out what do they want. Because again, one size doesn't fit all. And medicine, for most of your life, when you get medical care, you want everything that can be done to be done. And again, that's completely appropriate. But at the very end of life, that can change. And you can have patients, and there's a difference between what can be done and what should be done. I forgot that one. So look, it's always a little bit gloomy to talk about palliative care. I have to fess up straight away, and it can be a difficult talk to hear about. I work in the hospice. I've been there for 11 years in my current post, and I previously trained there. I've also worked in a hospice in London. For those of you who have been to a hospice or who have had family members in a hospice, I would hope that your experience of the hospice was perhaps different to what you expect. They're actually happy places. They're actually happy places to work. It's a wonderful place to work. And the reason it's such a good place to work is because we get to help people in a very immediate way and in a very important way. And I think care towards the end of life, and as I said, towards could be weeks, it could be days, it could be months, it could be years, but care towards the end of life is all the more important because time can be shorter. And I think the Irish Hospice Foundation and movements such as that, which have driven palliative care forward in Ireland, have made a real contribution to healthcare, a great contribution to healthcare. And I think now that the further development of palliative care, where patients perhaps are referred to palliative care earlier in their illness, I think there's further benefits, real benefits to be accrued there. Thank you.